I'm Dr. Matthew Biel. I am a child psychiatrist at MedStar Georgetown University Hospital. I am very fortunate to work with a terrific team of doctors here in the Department of Psychiatry that focuses really on working with children, families, adolescents, and young adults. We have a terrific team of psychiatrists, psychologists, social workers. We've got students and residents in the teaching components of our program. And we're really lucky to have a chance to work with families and with kids from across the metropolitan region here in Washington. We get to do work in our clinic. We also work in the hospital. We work in schools. We work in primary care offices in various parts of the DC area. And we really feel passionate about the work that we're doing. We feel like children's mental health is oftentimes something that's a neglected area of healthcare and that has such a powerful impact on long-term health and wellness for children and families. We know that mental health problems, when they present in childhood, are real and are treatable, and yet they oftentimes go unrecognized. And when they go unrecognized, they don't tend to get better on their own. The best experts on kids are their families. And families oftentimes know when something is not going right. When there's something going on with the child's learning, or with their emotional development, or with their behavior, that really just seems like a concern, like a problem, and families know we've got to talk to somebody who's really an expert to understand how best to help our child. We feel that the Child and Adolescent Psychiatry program at MedStar Georgetown is really uniquely constructed to meet the needs of the diverse families and communities of our region. We have a focus in our program on being very holistic, on being very family-centered in our approach to working with kids. We dedicate a lot of time in our evaluation process to meeting the entire family, to understanding the context that the child is living in, the context at school, the context at home and in the community, as well as understand the details of what's going on with the child emotionally or psychologically or behaviorally. And that careful and holistic and really ecological approach that we take to understanding and figuring out how to help children, we feel like has a big impact on the positive rates of success and treatment response that we see in our families. And we also know that mental illness, which is such a difficult problem to confront in adulthood, usually begins in childhood. 50% of all mental illness begins before the age of 14, and 75% of all mental illness begins before the age of 24. So mental health problems like bipolar disorder, schizophrenia, depression, addiction, these problems usually start in childhood and adolescence. And so if we as a culture and as a health system can identify these problems earlier, work on them, and bring our effective treatments to the folks that need them earlier in life, the long-term impacts are going to be really positive. Children do get depressed. Little children can get depressed. In understandable circumstances, things like grief or loss, or in the setting of abuse or trauma, kids can get depressed. Kids who have family histories, biological families in which there's a lot of depression or other mood disorders, are at a much higher likelihood of developing depression themselves. And so, while it may upend some of our expectations about childhood when kids are supposed to be happy-go-lucky and everything is supposed to be easy, the reality is that many children do suffer with mental illnesses, including depression, during childhood. Children who are depressed have some of the same symptoms and signs as adults who are depressed. They may seem sad or withdrawn. They may seem less interested in the activities that they usually are interested in. They may have disturbances in their appetite or in their sleep. And in other ways, children can look a little bit different than adults when they're depressed. They may just seem kind of bored and listless or low energy. They may sort of say no thanks when asked to do things that they normally would jump at the chance to do. They may sort of just seem tired all the time. And they may complain of being bored. Now, all kids complain of being bored sometimes, but kids who complain of being bored and not interested all the time, that's more than just being a little bit bored. That actually can be an important symptom of depression and something that's really worth investigating. There are terrific treatments for depression that have a really high likelihood of improving kids' symptoms significantly and really improving kids' quality of life. Now, the range of treatments for depression are wide, and they really start with psychological treatments. So they start with psychological therapy. So that might be individual therapy for a child. might be therapy in a group with other kids who have similar difficulties. It may be family-focused treatment to help families figure out how to best support their child. There are academic interventions, so there may be adjustments that need to be made at school that can be really helpful with alleviating depressive symptoms. We now know that exercise is a powerful intervention for kids who have depression. For kids who have mild to moderate depression, regular daily exercise is as impactful an intervention as psychological or medical treatments for depression. So there are a range of treatments, and then there is medicine for depression as well for kids. It's not the treatment that we start with for depression, but for kids who have severe depression, it oftentimes is important to think about medicine as an intervention. All kids have periods of time during development where they're more sensitive, more likely to worry, where they may sort of have difficulties with changes in their mood or moodiness, and that's an absolutely normal part of childhood. However, some kids, and it may be 10 or even 20% of kids at some point during development, have worries that are so strong that it's really impacting their daily life. They're worrying so much that they can't sleep. They're worrying so much that it's affecting their social life with their friends, their ability to form and maintain friendships. It's affecting their ability to participate in their learning. And they're affecting their performance in their family, their ability to effectively relate to and get along with folks in their family. When kids are worrying excessively, it's taking up so much of their headspace that it doesn't leave time for socializing and enjoying themselves and having fun. And so when families or parents see kids who are really overwhelmed by worries, where worries seem like they're just totally preoccupying kids much of the time, that's not a normal part of development. That's really a clinical concern, and that's worth talking to somebody about. Obsessive Compulsive Disorder is a really, really important psychiatric diagnosis. It's really important because it goes so long without being recognized. The average person who has OCD goes 10 years between the first time that they have symptoms and the first time they receive clinical attention. It oftentimes begins in childhood or adolescence, and oftentimes kids don't talk about it or let anyone know that it's going on. But it absolutely does occur in childhood and adolescence, and it is quite treatable. Cognitive behavioral therapy is a very powerfully impactful treatment to relieve the symptoms of OCD, and it is effective in childhood and adolescence as well as in adulthood. It's really, really important that all folks who interact with kids know about OCD and can pick up on kids who may be suffering with those symptoms so that we can get them to evaluation and treatment. Kids oftentimes do a really good job of hiding symptoms of OCD, but if you ask them about it, they'll tell you about it. So kids who have OCD oftentimes have repetitive worries. So they have the same worry or concern that goes around and around in their mind. They may ask themselves 10 or 50 or 100 times a day, is my parent okay? Is my parent safe? Am I safe? Am I sick? Am I going to get sick? What's going to happen next? What's going to happen next? What's going to happen next? And those repetitive, ruminative kind of worries, are, as you can imagine, are really distressing and take up a lot of bandwidth for kids. Kids also who have OCD have repetitive behaviors, so they may wash their hands, again, 10, 20, 30, 50 times a day. They may go and repeat a routine over and over again. They may repeat the routine of going up and down the stairs again and again and again. They may open and close doors again and again and again. They may not even know why they're doing those routines, but they get the sense that it can relieve their anxiety, they relieve their worries temporarily, and so they will engage in these repetitive behaviors in an attempt to relieve their worries. Child psychiatrists, like myself, are medically trained, so we go through 4 years of medical school and then residency and fellowship after medical school. So it's 9 or 10 full years of training that's postgraduate. And we have expertise in assessment of children in terms of physical development, neurological development, and emotional development. We do complex evaluations that involve both the child and the family. And we have the ability to prescribe medications as well as prescribe other medical tests and to consider the influence of medical health problems upon emotional and behavioral well-being and development. So we prescribe medicines, lab tests, brain imaging tests, as well as thinking about the psychological development of kids. Psychologists have a different training, also quite long. They do 4 or 5 years of PhD training, and then they also do clinical training after the PhD training. So psychologists are PhD rather than MD, and psychologists specialize in evaluation of kids. They specialize in assessment, so they do batteries of tests that look at kids' intellectual functioning, academic functioning, and psychological functioning according to very strictly defined and developed batteries that are called psychological and psychoeducational testing batteries. Psychologists are also experts in doing psychotherapy, so they do individual psychotherapy, group psychotherapy, family psychotherapy. They don't prescribe medicines. In our department, as I said before, we work very closely together. Many kids who are in treatment in our division have treatment with both psychologists and psychiatrists. The psychologist may be doing psychotherapy. The psychiatrist may be prescribing medication or other medical treatments. They work very closely together. We have a very team-focused approach working with kids and families. And as I mentioned before, some of our psychiatrists do psychotherapy on their own, and others refer to psychologists in our department for psychotherapy for kids who need that treatment. ADHD, or attention deficit hyperactivity disorder, is a brain-based neurodevelopmental disorder that affects kids' abilities to pay attention, to engage in activities that require sustained mental effort. It affects activity levels. Oftentimes kids with ADHD have high levels of activity or are hyperactive. They have difficulty controlling their impulses. And all of these qualities in ADHD are qualities that some kids have some of the time. Kids who have ADHD have many of these qualities most of the time, and they have the qualities so much that it impacts their functioning at school, it impacts their functioning socially, and impacts their functioning in the family. And we know from decades of research that ADHD is a real brain-based phenomenon. We know that it tends to improve over the course of development, but that kids who receive intervention earlier have a much better prognosis in the long term. And we know that ADHD is highly treatable, both with behavioral interventions as well as medical interventions. So parents oftentimes are concerned, how do I know if my child has ADHD? And the answer is to talk to the people who know your kid best. Talk to teachers, talk to your pediatrician, talk to the other child development experts in your family, namely the grandparents and the aunts and uncles and other folks who really know kids, and have conversations about the concerns that you have. Is this activity level normal? Is this in the normal range? Or is it really hyperactive? Is this child's ability to pay attention and to really dedicate themselves to a task in front of them, whether it's playing with Legos or reading a book or engaging in conversation? Are they able to do that in a way that's developmentally typical for their age? And of course that will be different for a 3-year-old as for a 13-year-old. Or is it really, the ability to pay attention, is that really a problem for this child and really impacting their functioning? I think ADHD is a complex phenomenon and diagnosis because so many of the characteristics that we know as ADHD exist in all children. And it's a dimension, it's a spectrum from having a normal amount of activity level and of curiosity and of moving from one activity to the next, and having so much of those qualities that they're really causing dysfunction. So it's understandable why people have a lot of concern and question about what is this thing, and is my child being pathologized or given a diagnosis just to explain normal child behavior. What we know from decades of neuroscience research is that kids who are diagnosed with ADHD do have differences in brain development that are really reliably found by careful investigation. It is a real brain-based phenomenon. At the same time, there are kids who are diagnosed with ADHD who don't require medication. They may require adjustments in the approach that's being used at school. They may require adjustments in the way that we parent those kids and think about the routines and the structures that they need at home. And some of those kids actually do need medication as well. When the concern of ADHD is raised in a child, rather than immediately rushing to a diagnosis and medication, or rather than immediately dismissing it out of hand of this is just a kid being a kid, I think that's where having expert opinion and evaluation really comes into play. Taking advantage of expertise from psychiatry and psychology to investigate what's going on with a child's development and figure out what does this child need to thrive. And that's the question that we really hope to answer. Autism is a very important and complex neurodevelopmental condition that begins early in life, begins in early childhood, and affects multiple components of kids' development. It affects their social development, the way they relate to other people. It affects their language development. It affects cognitive development. It affects physical and sensory development. So really almost every component of early childhood development is different in kids who have autism. Autism is diagnosable very early in childhood, as early as 2 or even younger than 2 years old. It's diagnosed by a multidisciplinary team of experts coming together. So that involves a medical part of the team, so either psychiatry or neurology. It involves psychology. It involves speech therapy, occupational therapy, often involves genetic assessment with a pediatric geneticist. So a team-based approach is critical to the accurate diagnosis of autism early in childhood. Now, early diagnosis is absolutely critical because we know that kids who have autism who are diagnosed early and receive early intervention services, so educational and therapeutic services early in life, have a far better long-term prognosis than kids who are diagnosed later who don't receive services until later. So it's really important that parents communicate clearly with their pediatricians very early in development to understand signs and symptoms of autism. Some of these signs and symptoms might include a lack of eye contact, a lack of interest in socializing and other people, a lack of communicating both non-verbally and verbally, delays in use of language, delays in motor skills. Now, all of these delays that I've mentioned occur in conditions that are not autism as well. So none of these are specific to autism, but I think it's really important. Pediatricians are getting more and more active in working together with families to pick up on these signs early in life, even by the first year of life, to look for some of these signs and to do careful investigation as early as possible so the parents can understand where their child's vulnerabilities might be developmentally and what can be done in terms of early intervention to help kids thrive developmentally. Medications are not a central part of treatment for autism. Particularly in early childhood, treatments for autism focus on psychological interventions, educational interventions, and therapies like speech therapy and occupational therapy. Medications are sometimes used for autism when kids are older, elementary school and older age kids. Sometimes medications are helpful to treat some of the symptoms that develop with autism later in life. So things like impacts that autism has upon attention and upon learning and upon impulse control, upon anxiety and behavior. But those are not where we start in our treatment plan for autism. Children and adolescents can be at risk for suicide, particularly in the setting of severe mental illness, depression, bipolar disorder, early schizophrenia. These are all conditions that do occur in late childhood and adolescence. And if they're left untreated or if they don't receive adequate treatment, they can present a real risk factor for suicide. Suicide is the third leading cause of death in late adolescents and young adults. It is a real outcome that we have to prevent. And the best way that we know to do that is to recognize mental illness when it occurs and to make sure that young people get access to treatment. We know that our treatments can effectively treat all of these illnesses. We have effective treatments for depression, for bipolar disorder, for schizophrenia, for addiction. All of these conditions that are risk factors for suicide can be effectively treated when kids and adolescents and their families get into good treatment. We have a vast evidence base now about the effectiveness of our treatments, both psychotherapy treatments and medication treatments. We have treatments that we know are safe, we know that are specifically helpful for children at different developmental ages, and that we know can be specifically tailored to different kids with different problems at different moments in time. And it's just critical that we reduce the gap that has historically prevented kids from getting to the treatment that they need. The suffering is real, the treatments are effective. Let's work together to make sure that kids get treatment that they need.